invite Dr. Varun Goyal. He is a senior consultant in Medical Oncology Department, Rajiv Gandhi Medical Institute, Delhi. So he will be talking about recent advances in management of metastatic prostate cancer, especially the PARP inhibitor in prostate cancer. Dr. Varun Goyal, over to you.
So, good evening, Dr. Asim, and thank you first of all for giving this opportunity, and thank you all my colleagues and seniors. So, I'm just sharing my slide. My slides are visible.
Yes, sir.
Yes.
So topic given to me for discussion today is what is the recent progress in the prostate cancer and mainly focusing on PARP inhibitors. So I am going to discuss about and what we should understand and should learn about with this presentation, that how we can identify patients with prostate cancer who should undergo mutation testing and what are the guidelines regarding that, and whether we should use PARP inhibitor in patients with prostate cancer and what is the safety and efficacy data and landmark trials in respect of that, and how we can apply recommend monitoring and management strategies for the management of adverse event with the PARP inhibitors. So first of all, as we all know that prostate cancer is not an uncommon disease. It is a most frequently diagnosed malignancy and second leading cause of cancer death in US males. And overall survival in metastatic prostate cancer, especially the CRPC status, is dismal. It's around 1 to 2 years only. So with bone disease, median survival is 21 months, with lung disease 19 months, and if patient present with liver mets, then overall survival is around 1 year only. So although mechanism of transition from CSPC status to CRPC status is not well understood, but these patients invariably occurs. This happens. So if initially patient show develop responses to ADT, but later they developed metastasis disease and increase in the PSA level and go on to CRPC. And once in CRPC status, their prognosis is dismal, as I already told. So, but still, why not this CRPC? We have omitted term of HRPC because still androgen receptor continues to drive these cancers, and even at castrate level, these receptors are important. And pathways independent of the androgen signaling are likely contribute for this. So this we all know that this is the natural history of the prostate cancer patients. From the beginning, locally advanced disease, initially they receive some definitive therapy, but with biochemical recurrence, they goes on to either in metastatic HSPC or metastatic CRPC and later develop metastatic CRPC. So all these stages of this prostate cancer is important because now we have newer drugs for metastatic HSPC also to treat. So that is beyond my discussion, and that most likely next discussion will be about. So about the mechanism of PARP inhibitors, and so because of different factors like environmental factors, including radiation and other chemicals, normal DNA replication physiology, and some chemotherapy and radiotherapy effect, DNA damage happens. So, but this DNA damage usually repair via different mechanisms, including single strand break and double strand break. So these PARP inhibitors usually act on these mutations, and so why we should do genetic testing in prostate cancer patients? So because BRCA1 and 2 and other DNA damage repair germline mutations have been associated with increased risk of prostate cancer. Around 12% of the men with metastatic prostate cancer have germline DNA repair gene mutations regardless of family history. So point to be noted here that all patients with metastatic prostate cancer, whether in CSPC status or CRPC status, should receive germline and somatic testing for mutation because of this history of germline mutation there, even without family history. So out of all genes, BRCA2 is the most frequent one, and it is associated with aggressive pathological features and poor outcomes. And because it is associated with genomic instability, increased frequency of SNPs and MYC amplification. And we should also differentiate between germline and somatic mutations because germline mutation is associated with 2 to 6-fold higher risk of prostate cancer, and it occurs mainly in the younger age and higher risk of regional and distant mets. What about NCCN guidelines? So NCCN guidelines recommend mutation testing, especially if there is high risk or very high risk in localized or regional disease and in metastatic disease in all patients, independent of family history. And if patient had some positive family history, then even in very early local disease also, we should do these testing. Otherwise, Ashkenazi Jewish ancestry, personal history of any cancer, especially male breast cancer or any other cancer, we should consider germline testing. Somatic mutation testing, as per recommendation, as per guideline, is only for metastatic disease. We can consider for regional disease based on other factors. And for this genetic testing, we should use multi-gene testing platform, which include these DNA repair gene alteration, including BRCA1, 2, ATM. Out of all these genes, these three genes, BRCA1 and 2 and ATM, are the more common one. And other genes also we should check. So always inquire about the family history of the prostate cancer. But beside that, also in metastatic disease, we should go ahead with the genetic testing. So what about the current indication in these metastatic CRPC patients regarding different PARP inhibitors? We have with us two options, olaparib and rucaparib. So for olaparib, for adult patients with deleterious or suspected deleterious germline or somatic HRR gene mutated metastatic CRPC. So it's not just for BRCA1 and 2, whether ATM and other genes also, if there any mutation is there, we can prescribe olaparib, who have progressed following prior treatment of hormonal agent like enzalutamide and abiraterone. So prior docetaxel exposure is not required for the prescription of olaparib. Select patient with therapy based on FDA-approved companion diagnostic. So for rucaparib, adult patient with deleterious BRCA mutation, either germline or somatic, associated with metastatic CRPC, who have already treated with the abiraterone or enzalutamide and taxane. In those patients, we can prescribe rucaparib. And so this drug have got accelerated approval based on the landmark study, like I'm going to discuss later. So first of all, for olaparib, what is the study based on which this drug have got approval? PROFOUND study. It was a phase 3 study, and in which they have taken patients of metastatic CRPC who had already progressed on either on abiraterone or enzalutamide or on both, and they have divided all these patients, which so they have recruited around 400 patients. So they have divided in two cohorts, cohort A and B. Cohort A, common mutations, BRCA1, 2, and ATM. Cohort B, other alterations which are less common. And then they have given those patients, they have randomized in 2:1 ratio, and trial arm, they have given olaparib 300 milligram twice a day, standard dose, versus physician choice treatment, which may be another hormonal agent or chemotherapy in most of the cases, mainly taxane. So then radiological PFS was the primary endpoint for this study, and especially in cohort 1 and cohort 1+2. So they have not analyzed radiological PFS, especially in cohort B, because that their number were less, and so they have combined both cohort 1 and 2 and only cohort 1. So in these patients in which BRCA1, 2, and ATM mutation was there, with the use of olaparib, median PFS, radiological PFS was 7.4 months versus 3.6 with the physician choice option. So clearly we can say that almost doubling of the PFS, hazard ratio is 0.34, p-value is statistically significant, and in this Kaplan-Meier plot, there is clear benefit with the olaparib in these patients, and that benefit have come within 2 months, and then that benefit goes on with the longer follow-up also. Regarding rucaparib, study name was TRITON-2. It was a phase 2 study, and so in which metastatic CRPC patient with either 1 or 2 lines of either abiraterone or enzalutamide and 1 taxane-based chemotherapy already have been received. In this study, they have reported confirmed PSA response in around 50% patient, and 12-month overall survival is around 73%. Overall response rate was similar. Either germline or somatic mutation was there. Overall response rate for BRCA2 was slightly higher than BRCA1. So for based on that, this phase 2 trial, phase 3 study, TRITON-3 is going on, and it's still recruiting the patient, and in near future we will see the analysis of that study also. So with the use of rucaparib, in radiological PFS, is median is around 9. So this is even better than the olaparib, but still this is just a phase 2 study. With phase 3 study, we will further see exact difference with the use of olaparib versus physician choice treatment. So regarding administration, so olaparib standard dose is 300 milligram twice a day, while rucaparib is 600 milligram twice a day, and dose adjustment for the adverse event. So in few of the common adverse event I'm going to discuss, and this is the adjustment. And if moderate renal impairment is already there, then dose should be 200 milligram twice a day in case of 300 milligram. And so 300 milligram twice a day is standard dose, but there are common side effects like fatigue, asthenia, nausea, diarrhea, vomiting, anemia, thrombocytopenia may be encountered with the use of olaparib. But most of the time, these side effects are grade 1 or 2 only. Grade 3, 4 side effects are very, very less. And most of the time, these side effects are very well manageable. So rare side effects, including MDS, we know thrombotic event, pneumonitis have been reported in different studies, either in the prostate one or other ovary and breast cancer trials. But these are very, very rare. And in rucaparib, rare side effect of MDS and embryo fetal toxicity have been reported. Other side effects are almost similar, but slight different side effect profile. Here we can see increase in the ALT, AST with the use of rucaparib. Dose is double, 600 milligram twice a day. Other side effects are same. So even with mild nausea and vomiting may impact patient adherence and quality of life. So nausea and vomiting tend to diminish over time. We should give prophylaxis for that. And patients should not take additional dose if they vomit after taking their PARP inhibitor dose. And as I've told you that most of the time, these side effects are grade 1 or 2. Grade 3, 4 side effects are very, very less. And beside anemia, rest of the side effects are very less. So anemia is the one. For that, we have to reduce the dose of these drugs in more number of patients. So if anemia develops, then we should hold PARP inhibitor at least if anemia is grade 3 or more. And otherwise, we have to transfuse blood that time. And once hemoglobin returns to normal level, then we can adjust the dose again. Dose adjustment is first we can step down from 300 to 250 milligram twice a day to 200 milligram twice a day, and rucaparib from 600 to 500, 400, 300. And even then, if anemia recur again, and then we have to discontinue the drug. So this treatment should be continued until disease progression or unacceptable toxicity. Patients who are receiving PARP inhibitor for metastatic CRPC, they should receive concomitant GnRH inhibitor or either should have undergone bilateral virectomy side by side. And we have to be alert for the less common side effect. Those are rare, but still we have to see for that, and we should counsel the patient to use sunscreen and avoid sun exposure to reduce rashes and all. So coming to other combination of other options, now these are the ongoing studies and other combination of PARP inhibitor with AR targeting therapy. So this is very interesting study, PROPEL study, in which in the first line with abiraterone prednisolone, olaparib have been tried in metastatic CRPC patients. So interim analysis have been published recently in ESCO GU in 2022, and so it is an international randomized double-blind phase 3 study in which they have stratified the patient, randomized patient in 1:1 ratio. Trial arm is olaparib with abiraterone with prednisolone, and control arm is only abiraterone. So until radiological progression, they are going to give this drug, and this is the interim analysis which they have published. So primary endpoint of PFS 12 month and at 12 month and 24 month, these are 71% versus 63% and 51% versus 33%. So there is clear benefit of adding of olaparib with the abiraterone. With abiraterone, PFS is 24.8 months versus abiraterone alone, it is 16 months. So p-value is statistically significant and hazard ratio is 0.66. So with BICR, if we review this, we analyze this, then also 27 versus 16, so even better PFS. So this is a option we can we have to see after maturing of the data, all the data and final analysis. So even in the first line with abiraterone, this combination of olaparib have shown good responses and statistically significant improvement in the PFS. Similarly, other PARP inhibitor, that is niraparib, have been tried in combination with abiraterone, and trial name is Magnitude phase 3 study, the first line setting only. So in which niraparib 200 mg once a day with abiraterone versus niraparib alone have been given. And so this study interim analysis have shown that with a median follow-up of around 18 months, nira with abiraterone 16.5 months are like PFS, and with abiraterone only 13 months. That is almost similar to every study, abiraterone 13-14 months, but with addition of niraparib it is 16.5. So here also not much difference of numerically, but p-value is statistically significant. And there is another study which is ongoing phase 3 study, which is for evaluation of the addition of PARP inhibitor with enzalutamide in the metastatic CRPC patient. Study names are Casper and Talapro. So in this study, rucaparib with enzalutamide with ADT versus enzalutamide alone in the Casper study. In Talapro study, talazoparib with enzalutamide versus enzalutamide alone is the investigator tried to relate the difference of addition of PARP inhibitor with the hormonal manipulation. So obviously these studies haven't shown any, haven't published any interim analysis till now, and recruitment is still going on. So with this, thank you. And any query?
Thank you, Dr. Varun Goyal, for your wonderful talk. And this issue of PARP inhibitor is emerging, and we all are learning about how to use and where to use and which place, which space we should place it. So your talk has given good light over that. And